Topic is Lichtenstein's hernioplasty video. Dear students, I am going to show Lichtenstein's hernioplasty video to you. It's a common procedure to be asked as an operative surgery. You should know open method. Skin incision is 1.25 cm above the inguinal ligament, parallel to the inguinal ligament medial 2/3. Skin, outer camper, inner carpus fascia is incised. External oblique very shiny area is incised along the line of incision, laterally and medially up to the external ring. Once it is incised adequately, it is held with the artery forceps, 2 artery forceps above, 2 artery forceps below. It is reflected upward in the upper leaf to dissect until adequate width is seen, where beneath that we can see the iliophagogastric nerve and conjoint tendon. Lower flap is reflected downward up to the inguinal ligament. Inguinal ligament is yellowish, golden yellow, shiny colored one, and you can see the inguinal canal with the cord structure and the sac. And once you see the inguinal canal, you can see the yellow inguinal nerve running there outside the cord. Safeguard it and open the cremasteric muscle. It is called the cremasteric box longitudinally. Once you do that, in indirect sac, you can see the indirect sac, which is anterolateral, pearly white, shining. So dissect the fundus, separate it from the cord structure, and hold the fundus with the artery forceps. Gently move proximally, dissecting without injuring pampinifal plexus of veins. What difference you have to identify as a thick cord structure. Then go back proximally until the external ring, until the internal ring, where you can see the extraabdominal pad of fat. Internal ring is the opening in the transversal fascia, and sac, indirect sac is lateral to the inferior epigastric artery, which should be dissected and identified. Sac should be dissected proximal to the deep ring or internal ring, that is called as high dissection. And once you do the high dissection, you can see that here you can see the conjoint tendon there, you can see the cord, you can see the inguinal ligament, golden yellow color. This is the cord structure which is dissected. This is the Cunningham clamp, hernia cord holding forceps. Cunningham's hernia cord holding forceps, it is cord holding forceps, Cunningham. You can see that the artery forceps is put that underneath and dissected properly. Then you can see the, and once you reach the sac proximally, identify vessels, everything, then you can go deep. Only use bipolar as much as possible. Over use of monopolar may injure the or cause a spasm of the vasculature around the cord, may cause testicular atrophy. See the neck of the sac, extraabdominal pad of fat, you can see there, and dissected up to the deep ring or internal ring. And these retractors are called as Zerny's hernia retractors, CZERNY, very commonly used. These cord holding forceps called Cunningham's cord holding forceps. So the dissection with the scissor actually over the neck of the sac, and once you dissect the neck of the sac, you can see there very nicely. And inferior epigastric artery, we have to go to identify extraabdominal fat. That is how exactly neck is identified. See that extraabdominal pad of fat very typically, and use bipolar whenever you want, and medially you dissect properly. Then of course you have to open the sac at the cord structure, at the fundus. Then put your finger, then reduce all content, then twist the sac. That's important. Twisting the sac is important because otherwise content will come back. This is the inferior epigastric artery. See, very nicely seen. Sac is dissected high dissection is important. This is the inguinal ligament. This is the posterior wall of the inguinal canal. Inferior epigastric artery is there. Sac is opened. Sac is held over the fundus. You put the finger to see that content is reduced. Then twist the sac and transfix it like it. See that? Do a transfixation. See that? There is a figure of 8 suture. Transfixation. That is exactly you have to do on both sides. Transfixation suture it is called as. And cut the tag. That is called hernioplasty. Hernioplasty. See that? And this is cut, and it goes into the deeper plane. It buries. Burial is very important. Automatically get buried. That means you have done the high dissection. See that it has gone inside. Then your conjoint tendon is identified. Inguinal ligament is identified. See that inguinal ligament is there. That is identified. You can see the retractor there. They are called Journey's retractor, hernia retractor. One is deep retractor, two Journey's retractor are used. One side it is biplane, one side it is flat. So that mesh is used. This is a polypropylene mesh, white in color. You cut it to accommodate the cord actually with the iliac nerve as a lower leaf and upper leaf laterally. Only half is cut so that you can encroach the cord. So that accordingly put always use polypropylene suture. 0 polypropylene 2 centimeter you have to overlap over the pubic tubercle. So put the suture, lower part it is a continuous suture. Up to the cord structure you have to put the continuous suture, polypropylene monofilament suture. So mesh is white in color, suture material is blue in color. That is the golden yellow colored inguinal ligament. What I am putting is Aberdeen knot. Lower part continuous suture, upper part you put inter suture, never continuous. You take care of iliac nerve. When you put the upper sutures, iliopagastric nerve should not be taken in the bite. Should not be included. We are putting the upper part. It was 2, 4, 6. 2 medially overlap the medial pubic tubercle, 4 above over the conjoint tendon. Laterally along the intersuperolateral spine, you have to overlap 6 centimeter. 2, 4, 6. 2 medially, 4 above, 6 laterally. So that is the point which you have to always remember. Interabdominal suture, remember. After that, external oblique you put with the continuous suture. So concluding with the vicryl it is used to continuous suture. External oblique course, then subcutaneous plane, then quinoa you can put subcuticular suture. That is inverting subcutaneous sutures have put inverting suture like this, inside out, outside in. Inverting suture, subcutaneous is put. And this is the monocryl 30 subcuticular suture. You are starting. This is absorbable, you don't require to remove it. But if there is a very large hernia, some oozing is there, seroma collection possibility is there, then don't put subcuticular, put interabdominal suture or stapler, skin stapler. Usually 30 ethylene or proline cutting needle, mattress, interabdominal mattress sutures will be put. But here we are using the continuous suture. This is the indirect sac, remember. Pearly white, anterolateral, pyriform in shape clinically, where direct sac is globular. So this is the conclusion. Typical subcuticular incision, subcuticular suturing, how exactly it looks like. See that? Subcuticular, don't require to remove it, it gets absorbed on its own. Put your own dressing. Then after 2 days they can remove the dressing and send the patient home. Of course after 10 days you can ask them to come for follow-up. Doesn't require anything for the wound. Some local application, ointment like betadine or ointment or something you can apply. Antiseptic ointment also you can apply. So that's how exactly you will do for indirect sac, open, Lichtenstein's, tension-free, onlay, mesh repair, hernioplasty. Students, so please go through my SRB's clinical methods in surgery, current edition. It gives a video like the examination of the different clinical situations. It gives a detailed examination method including history taking of swelling, ulcer, hernia, inguinal swelling, mass abdomen, breast lump, thyroid, neck swelling, salivary glands, all topics including briefly trauma, how to approach, orthopedic briefly. Then it also includes the instruments, specimens, images, briefly operative surgery, entire thing clinical method with a lot of photos, illustrations, each condition's photos are there, it's very clear. And analysis, history taking, detail, examination, general examination, history taking, history of present illness and past history, current history, treatment history, drug history, local examination, inspection, palpation, percussion, auscultation, clinical diagnosis, differential diagnosis, and briefly in a table form, all differential diagnosis. But it doesn't contain treatment aspect because clinical surgery book only for clinical surgery, analysis and differential diagnosis. So treatment should be checked in detail, principles of treatment should be checked in the manual, my SRB manual of surgery. So this is basically clinical book with the videos of each examination, with all illustrations, principles, different methods, different techniques, science. My service manual of surgery current edition gives a CBM syllabus, entirely covers all topics: general surgery, endocrine surgery, thyroid, breast, GI surgery, urology, cardiothoracic, neurosurgery, then other topics: arteries, disease, veins, its principles, methods, clinical methods, treatment, complications, approaches, with the quotations in the each page. It covers entire thing, including treatment principles, brief operative procedure also, not in detail. And it also covers briefly instruments, images, anesthesia, briefly oncological aspect, and daycare surgery, audit, surgical audit, metabolic response to surgery, pain management, everything covers as far as required for the CBM syllabus for UGs, PGs, and consultant, coming consultant also, with the illustrations, photos, a few video lectures, and a lot of MCQs online for each chapter with the QR code. Lot of MCQs for each topic, so each chapter it is there. Covers everything for UGs, PGs, CBM, MCQs, NEET exam, whatever required thing. Please go through it. Very, very useful book. My operative surgery, extensive voluminous book, 2-volume book, mainly for postgraduates and learning surgeons. All procedures, including major surgery, GI surgery, general surgery, thyroid, breast, and other things, include briefly gynecology surgeries, with step-by-step illustration photos, more than 10,000 photos and illustrations are, and which covers everything for to learner. You can, before surgery, they can go through my book and have a step-by-step for the all surgeries, whatever common surgeries, major surgeries, it is there. You can always go through that in detail. Explanations are there. My small atlas of tissue approximation with the videos shows clearly, with the principles, how to suture tissues. Dissection and tissue approximation, there are two parts in surgery. Dissection is a principle, essential. After dissection surgery, you have to approximate tissues, deeper layer, skin, softer tissues, everything, bowel, GI, everything. So this principle of tissue approximation clearly given in this book with the videos of it, including laparoscopic tissue approximation. So you can always purchase that and go through that. Very, very useful thing to develop the skin, which is essential for all surgeons. Students, I also request all of you subscribe my website, both in YouTube, Instagram, and so on. My DigiNow lectures to the JP publisher covers around 220 lectures in detail as far as CBME syllabus, from general surgery to specialty, urology, clinical examination, cardiothoracic, neurosurgery, all topics, GI, rectum, anal canal, colon, esophagus, liver, pancreas, breast, thyroid, neck, salivary gland, general surgery, artery, vein, everything in detail, all topics, theoretical aspect, surgical principle, operative surgeries, examination, clinical examination videos also. It covers 220 lectures, cover everything. 1 year purchase you can do. It gives detailed thing about explanations with wherever MCQs are required. You can make use of it and you can learn surgery properly as far as CBM syllabus and academic wise also. It gives lot of information towards the surgical field as such. So students, I hope you have understood this lecture very well, and also you can go through my books, all these books, with including DigiNow and lectures. Thank you very much. So students, I hope you have understood this video open method very clearly. Thank you so much.